welcome. My name is Elizabeth Vegas. I'm from Commonality, and I'll be your facilitator today. Our webinar is led by the Long COVID Alliance, Solve ME CFS Initiative, COVID-19 Longhauler Advocacy Project, Dysautonomia International, and Patient-Led Research Collaborative, along with support from the CDC Foundation. During the webinar, we'll be sharing our findings from our summer 2023 workshop series, where we identified the needs and priorities of the infection-associated chronic conditions community. We're going to start off with a little housekeeping. I'd like to begin by sharing that closed captioning has been enabled for this session. So for those that would like to view them, please go to your Zoom toolbar and click Show Captions. As questions arise during our webinar, please put them in the Q&A box. We'll do our best to answer them during our Q&A panel, but we might not be able to answer all of them. Looking forward, our agenda for today includes an overview of the IACCPAC project, presentation of workshop findings, panel discussions, and our roadmap of action. To kick things off, we'd like to understand which IACCs you all represent on the call. So we're going to make a word cloud. And we are going to watch the word cloud form together. I'm going to put a link in the chat box. You just click on that link and it's going to take you to a new screen. And there you're going to enter your IACCs. And we're just going to watch as that populates live. This is great. We're seeing a lot of great questions or answers. Wonderful. Dysautonomia, long COVID. Great. Anne is going to share her screen and we are going to see the word cloud. There it is. Okay, thank you. Wonderful. I'd like to welcome our first speaker, Ovid Amite, the CEO of Solve ME, who's going to provide an overview of the project.
Thank you very much, Elizabeth. And I'm with Solve ME, a patient organization that was established back in 1987. Dedicated to support people with myalgic encephalomyelitis, also known as chronic fatigue syndrome. And I am also a co-founder of the Long COVID Alliance. And the global COVID-19 pandemic obviously had many tragic consequences, but one of the outcomes was also that it created an unprecedented awareness of the long-term health implications of an infection. And in fact, COVID-19 is so prevalent that at the end of August of this year, the estimation is that there were at least 15 million adults here in the US who have long COVID. And many of them are still impacted in a very, very significant way. And of course, the impact is not only on the individuals, it's also on families and the society at large. We know that it affects quality of life, it stresses the healthcare system, and it also depletes the labor force. But long COVID also shed light on other complex challenges that are faced by people with similar conditions. And to name some of them, myalgic encephalomyelitis, as I said, also known as chronic fatigue syndrome or ME/CFS, postural orthostatic tachycardia syndrome, or POTS, and other forms of dysautonomia, mast cell activation syndrome, and persistent Lyme disease or chronic Lyme disease. There are some of the conditions that we became much more aware of as a result of long COVID. So in the face of this public health crisis, the CDC Foundation with the CDC was seeking to form a meaningful collaboration with patient advocacy groups, community-based organizations, really with the goal of better understanding and supporting those living with these conditions. So here's just a quick disclaimer. While the project was funded by the CDC and the Human and Health Services Department, the views that we're going to hear today are not necessarily the formal views of these agencies. And before we dive in, just a little about the terminology. We're going to be using the term infection-associated chronic conditions today, or in short, IACC, as a way to have a more inclusive term. Other terms that have been used are post-viral, post-infectious, post-treatment. But again, for the purpose of today's webinar and the project, we've been trying to use a more comprehensive term, the infection-associated chronic conditions. So how did this project start? It was really at the end of 2022 when the CDC Foundation launched the Infection-Initiated Chronic Conditions Understanding and Engagement Program, also known as IQ. And the reason that the CDC Foundation was interested in doing that at that time was really with the vision of bringing together diverse disease groups, patient organizations, mostly to promote collaboration among these groups. It was really meant to strengthen this cross-sector partnership among those different groups and identify the common objectives that the community has. It was also meant to increase awareness of infection-associated chronic conditions in general among the medical community specifically, but the public at large. And one of the more important aspects was to make sure that we bring representation to disease groups and diseases that are not as well understood and or resourced, and really use this as an opportunity to change the understanding of these conditions. And finally, it was really to identify the opportunities for collective action for us as a community to work together. And so in order to do that, the CDC Foundation built this program, and today we're at the last stage of the various steps that we're taking, initially with a landscape and stakeholder analysis to understand the space and the players. There were community conversations that took place, engagement sessions, which we'll talk about much more today, a summary report that the group is working on, and the national webinar that we're having today. So at the first step, the analysis was done to understand the space of infection-associated conditions, who are the players, and a key recommendation that came out of that step was the importance of creating a meaningful coalition of patient advocacy groups with the goal of collaborating and strengthening the partnerships among these groups to increase awareness and advance the needs of the community. And of course, this recommendation was further supported by additional conversations. The community conversations took place earlier this year, and again, there was a very strong desire to have a continued collaboration. There was a very strong belief that if we create a unified in a formal organization, a formal group to support infection-associated chronic conditions working together, that would lead to improved outcomes for the patient community. And so with that in mind, the CDC Foundation engaged two groups, one on behalf of the patient community, SOLVE, ME, with the partners of the Long COVID Alliance. And just as a reminder for those of you who are not familiar with the Long COVID Alliance, it is an unincorporated coalition, a coalition that came together really at the early stage of the pandemic as a grassroots effort to bring together many different groups, part of the Long COVID community, but many other infection-associated chronic conditions that work together. And today you'll hear from representatives of the four organizations that took part in this effort on behalf of the Long COVID Alliance. And we also had Commonality, a social impact consulting firm that works with nonprofits, philanthropies, and the government. And here you can see the participants, and we're going to introduce them to you shortly. And that's how we came together to work on this project. So there were two workshops that were conducted during the summer, and I will get into that in much more detail. But as a spoiler alert, I think the first part, in the first workshop, the discussion was primarily about the potential of a coalition, and really to begin to understand how would we work together, what the collaboration may look like, and really to begin to put together a framework for a shared community needs agenda across the different infection-associated chronic conditions. In the second workshop, we really started to refine the concept of how would we come together, and we're going to dedicate more time to that today, and particularly to clarify what are the potential areas that we would focus on as a patient coalition representing very different infection-associated chronic conditions, but they have so much in common. So at this point, I'd like to thank all the organizations that were involved in the project to date. I'm not going to name all of them, but as you can see, really coming from a very wide spectrum of disease organizations. And we thank all of you for your participation today, and we look forward to engaging with even more organizations as we continue to move forward. So now I'm going to transition to Lisa McCorkle from the Patient-Led Research Collaborative to present the findings of from the workshops that we had earlier this summer. Lisa, please.
Thank you, Oved. Hi, everyone. As Oved mentioned, I'm Lisa McCorkle. I'm a person with long COVID and one of the co-founders of the Patient-Led Research Collaborative, which is a group of people with long COVID and associated conditions who conduct research on the conditions. So I'll be reviewing the findings from our workshops. So first, over the course of the workshops, these 5 factors that are on the screen were really repeatedly stressed from workshop participants as really urgent, essential to why we need a coalition of infection-associated chronic conditions, so much so that we should use these basically as a litmus test for every decision. So as the coalition decides on its strategic direction, including governance, partnerships, objectives, initiatives, really using these as a framework. So these 5 different factors are to 1, build resources and capacity to support the critical work of patients and patient advocacy organizations, including increasing awareness of IACCs, identifying the needs of the IACC community, and again, building resources. Honoring the legitimacy of lived experience. Many of the orgs that were participating in these conversations are patient-led ourselves. I all aim to be patient-centered and really recognizing the legitimacy, power, and importance of lived experience, and using nothing about us without us as kind of a core theme. Additionally, centering the voices of historically marginalized, neglected, under-resourced, and under-researched communities. That includes BIPOC communities, queer and trans communities, disabled people, lower-income people, and people living in rural settings. Opening pathways to reduce the complexity of care, so really breaking down silos. And establishing and strengthening relationships between partners to grow IACC champions and allies. So these are kind of makes up the purpose framework for the coalition and the 5 main things that we want to see as we move this coalition forward. And using this as a framework, participants throughout the workshop really had a bold vision for what a coalition could achieve using this framework. So that included a vision of patient organizations coming together to bring us the biggest breakthroughs in modern medicine, breakthrough treatments, really changing the lives of people with these conditions. So a major output of this workshop series was to also identify and prioritize opportunities for action to drive this future coalition's focus. So participants identified these 5 main objectives toward collective action. 1, advancing public awareness of IACCs. 2, promoting comprehensive research. 3, enhancing patient and caregiver quality of life. 4, modernizing health systems. And 5, supporting clinician education. So under the umbrella of each objective, because these are huge objectives, workshop series participants prioritized activities according to this matrix, the Anderson and Belt's impact effort matrix. So this is often used to help prioritize actions when there's so much we can be doing. There's so many needs that we have. There's only so much bandwidth to carry these out. So this helps us identify where we should begin. So under each main objective, we developed a list of actions and asked participants to classify those actions for how much effort we estimate the action would take, as well as how much impact we estimate that action would have for our patients, for our community. So quadrant 1, which is in the pink quadrant, is high impact, low effort. So any actions ranked in there are really what we think is kind of like the sweet spot. So this would make very high impact, but take minimal effort. The yellow is high impact, high effort. So priorities within this quadrant make a large impact, but may be challenging to achieve. The purple on the bottom left is low impact, low effort. So these priorities might be simple to accomplish, but they also might not result in much progress, but still might be worthwhile as kind of a stepping stone to other achievements. And then green is low impact, high effort. So these activities require a lot of effort and deliver relatively little in return. So for each of the objectives that we had, each of those 5 objectives, I'll list the action and then what quadrant that most participants put each action in. And this really will hopefully help inform what the coalition takes on as its first priorities. So under advancing public awareness of IACCs, all of the actions that we identified were considered high impact. So what's in the sweet spot, this high impact, low effort quadrant? So that's educating the media to ensure that IACCs are represented in a fair and factual way that legitimizes patients' lived experience. Attending and presenting at conferences and events to increase awareness and education on IACCs. So that includes medical conferences, patient advocacy events. And then recruiting trusted champions and spokespeople to publicly discuss and educate about IACCs. So that includes the experience of living with an IACC, the prevalence of IACCs. Now, this one ironically was tied in responses for low impact, high effort. So more discussion on that one may be needed before prioritizing that one. And then for what would have a high impact, but also require high effort, that included creating a public awareness campaign in collaboration with providers, medical associations, and more to educate patients and caregivers about IACCs. Creating public-facing campaigns to counter stereotypes as well, include stigma, misconceptions about how IACCs develop, highlighting the experience of living with an IACC, and educating on the long-term health implications of IACCs. Under promoting comprehensive research, the sweet spot was to train, invest, and empower patient leaders to be active partners at every stage of the research process. Many orgs are already doing this, so really elevating that. SolveME has a really great LC plan project where they're educating patients on how to be involved in the research process. We've done work on this, and it really has shown that patients can be such an integral and crucial part of the research process, and we really need to empower patients to really step into that role. For higher effort but still high impact, participants identified creating a collective IACC research agenda that includes therapeutics, diagnostics, really the wide range of IACC research. Developing a central hub or database for trials, treatments, and patient registry. Educate on patient perspectives for the establishment of patient-centered research guidelines to ensure research designs support diverse communities and are of high quality. And identifying the epidemiology, disease burden, and socioeconomic impacts of IACCs. So again, all of those were identified as being very high impact, but also may take more effort to achieve. Under enhancing patient and caregiver quality of life, the sweet spot was developing patient education and resources. So that includes navigating systems of care, ensuring access to culturally humble care, communicating with workplaces, how to navigate insurance and workers' compensation, accessing disability benefits, just developing all of those resources for the community. And then developing caregiver and family education and resources. So additionally doing webinars, workshops, handouts to help caregivers and families really understand the implication of chronic illness for the household and learn how to support their loved one, any children living with IACCs, really support the caregiver through that process. Higher effort would be educating on the gaps and needs related to developing best practices to support patients in schools, workplaces, community spaces. That includes increasing awareness on IACCs as a disability, as well as accommodations and services available. Exploring the feasibility of establishing financial aid and other assistance to support patients and caregivers. So that includes paying for care and treatment, paying for transportation, covering mental health services, navigating time out of work, really accessing the services that are available. Under modernizing health systems, the sweet spot was to research or identify ways to leverage technology to improve patient access to care. So that can include telehealth across state lines. Higher effort, but still high impact, was educating on the need for and development of clinics or centers of excellence that integratively support patient care across disciplines and specialties. Partnering with private healthcare insurance companies to educate on the need to expand coverage of IACC related care and treatment benefits. Educating on the need for an IACC care coordination system that supports integrated patient care across different domains, conditions, disciplines. So having patient care coordinators, scheduling appointments, coordinating insurance approvals, determining care team members. And then partnering with medical associations and other health systems and stakeholders to inform the development of medical guidelines and care algorithms for IACCs. And then finally, supporting clinician education. The sweet spot was educating on the need for the development of a new medical specialty focusing on IACCs, including the eventual establishment of a medical association for IACC specialists. Developing educational resources and platforms to inform healthcare providers on the administrative aspects of navigating IACC care. So that includes ICD-10 codes and helping patients access disability supports. And then creating campaigns to reduce healthcare practitioner bias and increase culturally humble care toward patients with IACCs. That can include through social media ads, billboards, media, doctor's office posters, really wide range there. And then higher effort, but still high impact, collaborating with medical associations and universities to innovate clinician education and training on IACCs for both new and existing healthcare practitioners. And then promoting and incentivizing new and early career medical providers to specialize in what we hope to be a new IACC field. So what was identified as a sweet spot may be the first actions that coalitions could take on, while some of these higher effort items could be longer term priorities or have specific resources dedicated to those. But you'll notice that none of these actions fell in the low impact categories. I think that really speaks to how much is needed for infection-associated chronic conditions across research, healthcare, the patient experience, and really how much we need to collaborate and combine efforts and have this coalition to have the biggest impact. And now I believe I turned over to Karen Bischoff.
Hi, everybody. Good afternoon, and I would like to thank all of you for joining us today. My name is Karen Bischoff, and I'm the founder and president of the COVID-19 Longhauler Advocacy Project, which is a co-founder of the Long COVID Alliance. I currently serve as the LCA's chair for this initiative, and I'm a person with long COVID due to a March 2020 infection with COVID-19. I'm a single mom and former paramedic, and I have subsequently developed POTS, mast cell activation syndrome, ME/CFS, fibromyalgia, hypermobile Ehlers-Danlos, and unfortunately many other comorbidities. Today, we're going to be having a panel to discuss what an IACC coalition can contribute. And here with us today are several people with experience and expertise with IACCs: Ashanti Daniel, Krista Coombs, Liza Fisher, and Lorraine Johnson. Ashanti is a person with several post-viral IACCs, ME/CFS, two forms of dysautonomia, which is autoimmune autonomic neuropathy and POTS, and mast cell activation syndrome, which she has had for over 7 years now. Ashanti is a disabled nurse, former fitness enthusiast, as well as single mother, and has been a patient advocate with several chronic illness organizations since 2017. Krista has several IACCs, long COVID, two forms of dysautonomia, as well as OI and OH and ME/CFS as a result of her COVID-19 infection. And she is also a caretaker to two daughters, ages 13 and 17, who have had long COVID, POTS, and Lyme disease. Krista serves as the Director of Policy and Programs for the COVID-19 Longhauler Advocacy Project and is a long COVID patient advocate with the Vermont Center for Independent Living. Liza Fisher is an IACC patient with long COVID, multiple forms of dysautonomia, including postural orthostatic tachycardia syndrome, mast cell activation syndrome, ME/CFS, and complex regional pain syndrome. Liza is a former flight attendant and yoga instructor, is a board member of Dysautonomia International, executive committee member of the Long COVID Alliance, and is involved in several other research and education initiatives surrounding long COVID and its associated conditions. And last, we have Lorraine Johnson, an IACC patient who had persistent Lyme disease but is now recovered. She is the Chief Executive Officer of LymeDisease.org and the principal investigator of its patient registry, MyLambData, which has enrolled over 17,000 patients and published 6 peer-reviewed studies based on registry data. Thank you all again for being here with us today. I'm going to start with Ashanti. Hi, all. Ashanti, can you tell us a bit about your personal experience in seeking and receiving medical care?
Yes. So being completely transparent, I have to admit that although I am a Black woman, being a registered nurse gave me a false sense of security. What I am saying is, because I'm a nurse, I felt I was immune to structural violence in healthcare. That was, of course, until it happened to me. For those of you who are not familiar with the term structural violence, it is defined as the multiple ways in which social, economic, and political systems harm certain groups of people, producing and perpetuating inequality in health. While working as a neonatal intensive care unit nurse in August 2016, I became ill with a virus that attacked my lungs. Because I have a history of asthma, doctors just assumed it was a severe asthma exacerbation and subsequently treated me for that. Even though I was a nurse equipped with what I thought was inside knowledge on how to navigate the healthcare industry as a patient, I still encountered physicians who did not take me seriously when I told them early on that my symptoms were caused by something more than just a severe asthma exacerbation. 4 months into this illness, and after multiple hospitalizations spent relentlessly advocating for myself, I was finally able to get an appointment with an infectious disease doctor at a world-renowned medical center. I arrived to this appointment desperate, but optimistic that I would get closer to finding out what was making my muscles profoundly weak, my voice unusually hoarse, causing cognitive dysfunction, triggering what I now know was post-exertional malaise, causing bone-crushing fatigue, and other bizarre new symptoms. The infectious disease specialist talked to me for maybe 5 minutes max, ordered some blood work, did not physically examine me, so he didn't touch me at all, and sent me on my way. To add insult to injury, I requested a copy of my medical records and learned that the infectious disease doctor had written my illness was likely psychosomatic. Wait, what? Like, I was just, can you imagine the shock, devastation, dismay? All the words that you can think of that I felt while reading that consult note. In that moment, I was quickly reminded that being a registered nurse and, quote, one of them, does not negate the fact that I am a Black woman. And due to structural violence, I am far less likely to be believed and properly cared for than white men and even white women.
I hear this experience from so many across the IACC community, and, I wanted to hear from you. Do you hear this from other patients? Do you feel that this experience is similar across the board?
Across the board, especially for Black women, is almost identical. So me having expertise as a nurse while in some ways has benefited me, it definitely does not save me from or protect me from structural violence in healthcare, and implicit bias really is what it is as well.
Thank you for that. Krista, moving on to you. You're a long COVID patient and have been diagnosed with 2 forms of dysautonomia, orthostatic intolerance and orthostatic hypotension, as well as ME/CFS as a result of your COVID infection. You're also a mom and caretaker of 2 children with long COVID, POTS, and reactivations of Lyme, CMV, and EBV due to their COVID infections. Can you talk about your own experience in trying to obtain medical care, as well as your experience as a caretaker trying to obtain medical care for both you and your children?
Sure. Thanks, Karen. So our experience is very tied up together, as my daughters and I all got sick at the same time with similar symptoms that were new, debilitating, and intense, and that would also come and go. The first 2 years were especially difficult, and since the summer, we've had multiple infections, which again have worsened our symptoms. So I'm very happy to be able to be here today. Since we live more rural, most of our doctors are over 2 hours away and over state lines, and we got our first infection in February 2020. At that time, my children were 10 and 13, and now they're 13 and 17. We learned about long COVID finally in August of 2020. My husband and I have both been the main caregivers because I have not always been well enough to care for myself or for my children. In terms of medical care, all of us have the same primary care doctor who knew us well beforehand and was able to refer us to many specialists. I couldn't get into the Albany or the Dartmouth long COVID clinics that were nearest to me because of a lack of proof. So we had to figure everything out for ourselves. We all had regular blood work, which mostly came back normal, except for the reactivations of the past infections we had had and below normal hormone levels. We ended up seeing specialists like ophthalmologists and optometrists for all of our new vision problems, a Lyme specialist for my daughter's new positive tests, cardiology for dysautonomias, such as the POTS diagnosis for my children, and for me, hypotension. And then I also saw an ear, nose, and throat doctor because I was having trouble swallowing and speaking. And I went to neurology for these almost constant headaches, as well as numbness, energy loss, difficulty thinking, and chronic insomnia. My youngest daughter saw a gastroenterologist for trouble digesting and eating, and she also had an MRI for her headaches. And then in mid-2022, we found an MD who understood infection-associated conditions like Lyme, ME, and long COVID. And he was willing to try different medications with us. And he gave me a long COVID diagnosis and an ME diagnosis. Throughout these 3.5 years, while many of our doctors tried to be helpful, I found myself spending a lot of my time educating them instead of getting help for us. There were many doctors who also discounted the severity of our experience or were quick to suggest that it was psychological, like we should just stop thinking about it and maybe we would get better, or that we needed to build up our resilience because we were obviously not equipped to handle the pandemic, or that exercise was a solution when we could barely stand up.
Krista, thank you so much for being so candid about you and your children's experiences trying to obtain medical care. As a single mom who is now disabled from several IACCs, I couldn't imagine having to deal with my own medical care and coordination in addition to that of my child. I'm sorry that you're going through that, and there's so many of us out there who are going through this balance. With that said, in your opinion, what would you want the public and healthcare providers to know that can improve quality of life for those with infection-associated chronic conditions?
Sure. So in my view, we can improve the quality of life by always recognizing and supporting patients' needs. So this kind of includes having doctors who truly listen to us, recognize and value the experience of individuals regardless of age or background. Creating a fair and consistent healthcare system that isn't dependent on one's job, improving healthcare access to those who are homebound or bedbound, living in rural areas, and have disabilities, things such as telehealth that is accessible across state lines, and increasing home healthcare. developing, I guess, treatments to relieve the symptoms and also treatments to address our root causes, and then invest in more research and researchers who are interested in these conditions, provide ongoing education for healthcare professionals to keep them up to date, and then also encouraging better communication so we can understand these conditions within our society. It's not many people understand this at all.
I think those are great recommendations, and I think they'll lead to a better quality of life for both patients and their loved ones. I think many here would agree with those suggestions. Thank you. Now turning to Liza. Hi, Liza. You heard Krista and Ashanti discuss many of the barriers faced by those with infection-associated chronic conditions. Do you believe that public awareness or challenges with awareness and education surrounding IACCs contributes to those barriers? And please, feel free to include any barriers that you have personally faced yourself.
I 100% believe that the lack of public awareness creates a lot of challenges and contributes to the barriers. I have very similar experiences to what Ashanti shared, and I wrote down that statement that she shared: structural violence in healthcare. And thank you for defining that for everyone on this call. I think that's really important because so many of us do and experience that, and quite honestly are afraid to speak out about it because of our experiences. And so I think having that awareness, not only about the accessibility and the difficulty getting it, but the knowledge of what it is. It starts with, first off, just being believed when you walked off into the office, and being able to make it there, having the accessibility, having the coverage, having the affordability, and the access, and then not having the fear of being made worse. And I think that's something that everyone who has an infection-associated complex chronic illness, and anyone who is of a marginalization, not only race, but sexual identity and orientation as well. I think it's important that we acknowledge difficulties for everyone.
Just a few minutes ago in Lisa's presentation, we saw community goals included the need for increased awareness and education on IACCs. In your opinion, how can we improve awareness and education about IACCs across not only the patient and caregiver populations, but also innovate education for clinicians and researchers that help improve models of care, improve patient outcomes, and overall resources available?
I think the first step is to make sure that all of the way we do this is to be patient-centered, not patient-focused or not patient-involved, but patient-centered, and involving the patient from every aspect from the ground up, in designing clinical trials and creating protocols and what type of guidance, not only the education, but the guidance that is followed for the healthcare providers. I think in also focusing on a interdisciplinary approach, not just a multidisciplinary approach.
I think what you mentioned is a great start, and fully recognize and emphasize that we have a lot of work to do surrounding awareness and education. But I truly believe that we're at a pivotal moment where our collaboration can address some of those concerns. And with that in mind, we also need the research, right, to support some of the awareness and education. So I'm going to go to Lorraine. One of the largest needs of the IACC community is research investigating the overlap, commonalities, and pathophysiology causing IACCs, which we've heard a lot about today, and all of our panelists reflect. In your opinion, how would the implementation of this type of comprehensive and inclusive research improve patient outcomes? You're muted. Yep.
I apologize. I think it's important that we understand what these diseases have in common and how they differ to understand the pathology and possible treatment approaches. Some treatment approaches, particularly symptom management, may overlap and work for multiple conditions. But given the fact that we're talking about diseases that have an infectious etiology, we have a true potential to establish cures. And so, for example, by determining the mechanism of persistence, if one exists, or trying treatment approaches consistent with infectious etiology. We also share many unique challenges in Lyme disease, and I think this is common for some of these other conditions as well. Most patients are not receiving medical care in mainstream clinics, but in specialty clinics. And that's where the innovation is occurring. So most often this care is not available at academic centers or covered by insurance. And these structural barriers affect not only patient care, but also research capacity, because they create a fragmented medical and research environment, which makes it difficult to develop coordinated research structures that are necessary to accelerate the pace of research. But we need to capture data from these specialty centers because that's where the innovation is taking place. And we also have this extraordinary opportunity for cross-fertilization of ideas. When these I was so struck at the NASM conference when all the diseases came together at how many overlapping parallel themes there were, and that scientists were being exposed to for the very first time by listening to each other in a cross-disciplinary fashion. And I think that that was just extremely powerful.
So it sounds like we need to revolutionize research to develop modernized models of care for people with IACCs. In your opinion, what do you think are, the critical pieces of the IACC experience to share with researchers to help support coordinated research?
Well, I think that researchers need to understand, and I think I'm borrowing this expression from long COVID, that patients do not want Band-Aids, they want cures. They want to be restored to their previous baseline of health before they became ill. So, doctors typically practice using evidence-based medicine, but evidence-based medicine requires a previously established research base of clinical trials, which takes decades to build. With infection associated conditions like we have, we're starting at ground zero and are just beginning to build a knowledge base. So, we can use traditional research approaches like randomized controlled trials, and they're certainly important, but they're inherently slow, and they provide incremental progress measuring a single intervention at a time. We need quicker research approaches if we are to provide patients with treatments during this lifetime. So I think what we need is an all hands on deck approach in terms of utilizing all research resources, particularly big data tools. Patients are trying innovative treatments, so we need to capture that data. That's one of the things that we're doing with the MyLyme Data Patient Registry. And I think also because of insurance burdens and regulatory risks, clinicians are often reluctant to offer patients treatments that are clinically innovative. And we need to change this because clinical innovation has led the way to significant improvements in patient treatment interventions throughout history. And we need to capture the results of clinician innovation in patient databases as well, or clinician databases. So, some treatments won't work, but some may cure. And finally, we need a sense of urgency because patients can't wait decades for research that may never come, and they shouldn't have to.
Lorraine, I fully agree. And I think the time is now to really address this. Our need for coordination and collaboration amongst communities is needed and, of course, highlighted across our workshops and listening sessions. And the need for an IACC patient advocacy coalition, again, needs to happen now. We've discussed this need for a coalition and collaboration, in each of your opinions. How can we collectively accomplish more together than we can in our different silos? And, I'd love to hear each of your responses regarding this proposal and a need for an IACCPAC and why we're better together than alone. And I'll start with Ashanti.
Quick to add to that, I would say historically and in many facets of life, there has been power in numbers. More people raising awareness and educating people on IACCs is our best chance to secure more research, to adequately treat and hopefully cure these conditions. And the other issue is that so many of us are too sick to raise awareness. So if we join together, then again, there's going to be larger numbers, which tend to be conduits to change.
Krista?
Yeah, so building off of that, for me, I'm looking at kind of visibility more for caregivers. So collaboration can also bring attention to the crucial role that caregivers give, and the fact that they do need more support and recognition, including financial compensation, and also increasing awareness, not only about our own struggles, but about the challenges that our children face in dealing with these conditions as well. So when we come together, we build solidarity and we can shine more light into all these other populations of people who are often left behind and not thought about.
Liza?
Yeah, I kind of want to relay it to my overall holistic healing journey thus far. I didn't see one specialist. I didn't take one pill. I didn't go down one route. I had to address dysautonomia, various forms. I had to address POTS. I had to address EDS. I had to do this. I had to do that. I collected a team. That's the only thing that got me this far. And I think that probably may resonate too. So why not approach this at a grand scale as a team, collectively? Because I think that will not only help us get what we want, but also help us heal and do it with ease together.
I think that was beautifully said, Liza. And Lorraine?
Well, I think there's a real magic that can happen from people coming together and collaborating. One person says one thing, somebody else says another from a very different perspective, and suddenly there's a conversation going that hasn't happened before. And I certainly saw that at the National Academy of Science, Engineering, and Medicine event. And I think that type of discussion is just really energizing and gets the focus where it needs to be. And it also provides research opportunities. So for example, you may have one researcher doing a study who decides to add on an arm that includes chronic Lyme or that includes long COVID. And now you're able to start comparing how these different diseases are showing up. So for example, you could do this with biomarkers. How are these different diseases showing up in terms of biomarker identification, which is challenging. And researchers are using different approaches to identify biomarkers. So I think there's something that people can learn from each other when they collaborate.
Each of you have brought such tremendous value to this conversation, and your uniqueness and similarities have highlighted why we are stronger together than alone. I firmly believe in the future of such a coalition and the good that it can do. I want to thank each of you for being here today and sharing your experiences as patients or caretakers of patients with IACCs. Patient-centeredness and leadership is a priority, and we are thankful you have chosen to lend your voices and your spoons to us today. So again, thank you. And with that, I will hand it back to Elizabeth.
Thank you. Thank you, Karen. And thank you to all our panelists that came on today to share their story. I too have a similar story as well as a facilitator, so I can really understand how all of you felt. I would like to introduce our next panelist, Lauren Stiles, the founder, president, and CEO of Dysautonomia International.
Hi, everyone. Can you guys make it so I can share the slides? Great. Thank you so much. My name is Lauren Stiles. As Elizabeth mentioned, I'm the founder and president of Dysautonomia International. I'm also a person who's lived with POTS and Sjogren's syndrome for over a decade. And at the start of the pandemic, I had what we would probably now call long COVID for about a year. And I consider myself very lucky to have sort of gotten back to my baseline sick. So I want to talk a little bit about where do we go from here? We've done this great sort of visioning process where we had lots of different patient advocacy organization leaders providing input into what we think our shared priorities and goals are for infection-associated chronic conditions. And so how do we take that and kind of take the next steps? So one of the things we wanted to do as part of this is to kind of get an understanding of our webinar audience, to understand what different sectors are you part of. Are you from the government? Are you from a patient advocacy organization? Are you a clinician? So we have a little poll that Elizabeth has just popped up. So if you want to vote on your poll, and you can pick multiple options, because we know a lot of people wear multiple different hats. So I'll just wait a minute or two for that. Elizabeth, do you have the results of this that we'll be able to see?
Yes, I think it should.
Yep, we will end the poll in just a moment once everyone participates and share the results. We have some rapid fire participation, which is wonderful.
Great. So while we're waiting for that, we think it's really important that this coalition is really led by patients and for patients. But we very much recognize the value of other community partners. And so there will be roles for clinicians, for researchers, for the private sector, for government, for other nonprofit spaces, nonprofit entities, healthcare administrators. I think it's really important that we get all hands on deck. And it seemed like most of our patient advocate organizations kind of understood that concept and agreed with it. So here's the sector representation. We have a lot of us on this call are people who have some form of infection-associated chronic condition. We have some caregivers, some researchers on here, some government folks. So it's a good breakdown of people from different fields, and we appreciate that. So I'll just move on with the slides. So we've talked about a lot of different priorities and a lot of different sort of ranking of those priorities and what we think will be the hardest or the easiest to work on. But just to kind of summarize, we really had a broad consensus for engaging in cross-discipline research on IACCs. And so for any of you who've been part of the IACC community for a while, many of us have multiple diagnoses, as some of our panelists did earlier. And what we see a lot is that the patient advocacy organizations, the patient communities, are often sharing information with each other. I run Dysautonomia International. So in our support groups, we have a lot of people sharing resources about EDS, Ehlers-Danlos research, long COVID research, ME/CFS research, but we often feel like the researchers are kind of stuck in their silos because they're so focused on the one condition they're trying to figure out. So we need a lot more collaboration amongst the researchers and talking to each other and learning from each other and doing collaborative research across these conditions. So we all related to that is we want to have facilitating that information and knowledge sharing, and really getting these researchers to talk to each other, to break bread with each other, to sit down at a bar over a beer. I often find that the best research collaborations that come out of Dysautonomia International actually happen at the hotel bar at our conference, where we have two doctors just sit down and have a beer with each other and talk about what they're working on. And that's get that in-person connection and that real ability to have conversations about what they're seeing clinically and what they're finding in their research can really facilitate great collaboration. We need more public communication campaigns on all of the IACCs. That's a universal consensus-based thing, and from all of these communities or communities within the community, that there's not enough awareness about infection-associated chronic conditions, and that this delays diagnosis. And this also leads to people, when they are diagnosed, not necessarily getting the support they need from their community or their doctors. So increasing the public communication campaigns to let people know about this. Improving the clinician education. We can do all of the research in the world, but if it isn't translated into better clinical care, it's not really helping patients. So we really, really need to amp up the clinician education at the highest levels, not just each of our organizations individually doing a lecture on Lyme and a lecture on long COVID and a lecture on dysautonomia. We really need systemic change in how clinician education happens at medical school, at nursing schools, and throughout the career of a clinician. So we also had everyone agreeing that we wanted to develop interdisciplinary and multidisciplinary clinical centers of excellence that have broad expertise in IACCs. Because as we noted before, many of these patients have more than one IACC diagnosis. And sometimes this runs in families where mom has ME/CFS, and the daughter has POTS, and the cousin has long COVID. So we really need uniform centers that can study the broad range of these conditions and how they overlap, and also making sure that patients don't have to go to 15 different doctors to get care for one condition. And then we also have to do some work educating people about the treatments and the resources that are available that improve patient and caregiver quality of life. Well, we don't have a fantastic, highly effective treatment for most of these conditions, or really any of them. We do have some treatments that are somewhat helpful, and we do have resources that make your life a little bit easier to live with when you're struggling with a difficult condition. So there's got to be some effort into providing people with information and resources on what's available right now, not just always just looking forward to the new research, which we are, but actually, boots on the ground doing stuff right now. So how do we get to this big vision of helping all of these people with IACCs and moving the whole field forward together? It's certainly a big vision and a lot of people involved in it. So for right now, the immediate next steps we're asking everyone to take is to disseminate the findings from this workshop. So we're doing this webinar. We're also going to have a public report that will be released, and we will, I believe we're going to be emailing everyone that had signed up for this when that report is available. We're also going to host a third workshop in December, so we encourage everybody to stay tuned for more details on what that's going to be about and when it's going to happen. And then some other things that you can do in your free time. If you're not already signed up, join the IACC Coalition email list and invite others to join. This is, you don't have to be a patient to do this. You can be anyone who has an interest in supporting the broader IACC patient community, learning about research, learning about opportunities to collaborate. So we encourage everyone to sign up at contact@iaccpac.org. And you can also let us know if you're interested in volunteering. We don't have staffing or a formal structure set up, but we're trying to get a sense of who's out there that might be interested in helping. So if you're interested in volunteering, let us know what your skills are, what your interests are in potentially volunteering for this kind of coalition. We're also asking people to get the word out on social media. Right now, IACCs, most people don't know what that means, right? There's maybe a lot of doctors who have used the term post-viral or post-infectious. We're really trying to expand the concept and be more inclusive. And so getting the community to understand what IACC means is really helpful. So if you can talk about it on social media and share your story, if you have an IACC or if you work with people who have IACCs as a researcher or clinician or in a government sector, just get the word out on social, start using this hashtag and letting people know what it is. Then you can also, we'd ask people one of the best ways to collaborate with another disease community is to actually learn what's the same and what's different about their disease compared to your disease. So for example, over the course of many years, I've racked up a lot of the syndromic labels, POTS, IST, ME/CFS, mast cell, long COVID, Sjogren's. But each of these disease communities has so much overlap, right? And it's so easy to think, oh, well, that symptom must be caused by this diagnosis. And I think the more you learn about these other conditions, the more you realize, wow, there's a lot of overlap here, and we need to do collaborative research to really figure out what are causing these different things, and are the treatments that are helping one of these patient communities may be helpful for the other patient community too. So take some time to learn about IACCs that are different than the ones you might be diagnosed with. And you can also follow the different people who are doing the hashtags for these different conditions. There's a lot of them if you're on Twitter. So there's just a few of the examples. right? And then I just wanted to say, anyone on here in academia, or if you're a journalist or you're in government, if you're talking about one of the IACC conditions, it would be really great to amplify the concept of IACCs and discuss how what you're talking about in your one IACC is possibly relevant to the other IACCs. And the concept is a rising tide lifts all boats, right? If we're all just in it for our own diagnosis, it doesn't really lift the entire boat. We're all on the same sinking ship, is maybe another analogy, and we need as many people paddling and helping us get to shore as possible. So there's another feedback survey we're going to do. We want to hear your ideas, especially because you heard about some of the priorities today, and we'd love to hear your feedback on that. Do you have suggestions to build a strong IACC coalition? I think Elizabeth is going to share a link for that. Right? It's in the chat. It's a SurveyMonkey link, and it's just a few, like 3 or 4 questions. We would love it if everyone could just take a minute or 2 to fill it out and give us a little bit of feedback. And that survey will remain posted. So you can do it right now, or you can do it at the end of the webinar. But I think we're probably moving on to our Q&A panel at this point. So I will turn it over to Emily Taylor from Solve ME, who is going to be hosting our panel.
Hello. Thank you, Lauren, so much. It's so great to welcome back yourself and our other presenters today. We have Ovid Amate from Solve ME, Karen Bischoff from the COVID-19 Longhauler Advocacy Project, and Lisa McCorkle from Patient-Led Research Collaborative. If you all could come on back over. Yay. Thank you all for joining us. And we're going to tackle some of these amazing questions that you all have been sharing in the Q&A function. Thank you. I've been trying to get to as many as possible, but there's some that were just really rose above and wanted to share that tackled a lot of what we were looking at today. So the first question I'd like to offer everyone on the panel an opportunity to present on this one, but Karen, I'd like to target it to you first. How are the marginalized and underrepresented constituencies included in the groups that are currently leading this effort? How are we including the BIPOC communities? And the follow-up to this was about representation. How are we including the BIPOC communities, other gender minorities, LGBTQ plus IAA? How are we integrating all of these different approaches from other perspectives into the work that we're doing?
So for everybody on this call, I myself am half Indigenous, and our team has several BIPOC members. And I would highlight that several of the groups that are participating in this effort, who have chapters of their organizations, have specific chapters to connect with some of these communities to better focus in on and highlight some of the barriers that are faced by those, many of which you heard spoken about today. We have a saying in the community, nothing about us without us, and we have to be representative of our entire community, regardless of what that looks like, regardless of where they live, regardless of their demographic backgrounds. We have a strong drive to promote disability economic justice and to serve communities that were harder hit by the pandemic, that face more barriers to medical care, that are commonly left out of research or not represented as much as they should be. And those are things that we've been working on across the board with all of our organizations independently. And that's part of also what makes this coalition so strong, is we get to bring those things together and emphasize those needs collectively. And I think we talked a lot about that today with the overlap in our communities and learning what's the same and what's different. And medical care is one of those similarities.
Fantastic. Karen, thank you so much. Would anyone else like to jump in? Ovid, I'm kind of looking in your direction, but I don't want to put you on the spot. But if anyone else wants to jump in to speak to how your organizations are also bringing these underrepresented and misrepresented voices into the conversation.
Yeah, maybe just to add it, I think it does take intentional effort. I think that our organization was actually established back in 1987, and as a response in some ways to other viral outbreaks at the time. And I think we need to recognize that there are certain biases. We talked about that at the beginning of this conversation, and we really need to work actively to change that. So that's one of the one of the things that COVID-19 really exposed was all those faults in the system, and this is really the opportunity to change that. So I think for many of us, COVID-19, tragic as it is, was an opportunity to reimagine some of the things we're doing, some of the ways that we work, and we must take this as a challenge for all of us to become much more inclusive and really work specifically to address those needs. So it's not going to happen necessarily if we don't do that. It's not going to happen organically. We really need to be intentional, and I think that's one of the things that our organization has set up as a priority. But for all of us working together, it's a major common goal.
Absolutely, and just to share a little bit, at SolveME, we do have the Lived Experience Task Force with shared decision making, which is which has a extensive representation of folks of color, and that sort of informs our internal policy making. Lauren or Lisa, would you like to share a little bit about what your organizations, how you incorporate these voices?
Sure. Lisa, you can go first.
Yeah, I just wanted to mainly talk about, moving forward with this coalition. It's going to be so critical for us to be really intentional about being as inclusive as possible. With long COVID, because COVID impacted, mainly or like targeted marginalized populations already. There's already healthcare biases. Like, we need to make sure that we're representing everyone that long COVID represents, and then also all IACCs. Transgender people have the highest rates of long COVID. People of color have higher rates of long COVID. And so as patient-led research collaborative, we aim to be intentional about including all marginalized people within our research and within our groups, but that expands to this coalition. And so we need to make sure that as this coalition is being formed, that we are including groups that are under-researched, that are under-resourced, and really make sure that that is the forefront. That was one of the key themes that was discussed in the workshops, but it can't just be kind of lip service. Like, we need to actually follow through with that and really be intentional moving forward.
Yeah, I would agree with that and everything you guys have all just said. In terms of what we're doing at Dysautonomia International, we have a pretty uphill battle because the mindset of most dysautonomia researchers, particularly in POTS, has always been, pretty much promoting the idea that this is a white woman's disease because that's who shows up at the research studies. So we've been sort of, challenging that narrative and having some pretty forceful conversations with some of the researchers saying, you need to do a better job with recruitment. You need to realize when you are publishing a paper that the words you use can actually really make it harder for people to get diagnosed if you're reiterating this and you're not acknowledging that discrimination and disparities play a huge role in who gets access to the specialty care that most of these patients need. So we've developed Black support group, LGBT support groups. We have foreign language support groups in Spanish and French and a couple other countries. We've helped other organizations get started in, and I think we started support groups in Africa and India, and we're really trying to get people to recognize that POTS and other forms of dysautonomia are a global problem. They are not just a white girl from New York problem, that they are very impacting everyone. And actually, very interestingly, in long COVID, when we see the long COVID dysautonomia patients joining our support groups, they are much more gender diverse and racially diverse than our pre-COVID POTS community, which I think is interesting. Is that because COVID impacted people differently, or because there has been a conversation around this, that there is this gross disparity in our healthcare system. So I'm very hopeful that this coalition is going to tackle that issue head on and not minimize it, but really point it out as a big important thing that needs to be addressed.
Fantastic. Thank you so much. And I just want to shout out and share that especially the transgender community was recognized by one of our questionnaires. So thank you, Lisa, for recognizing that community, because that was one of the questions we also received. So I think we answered that one as well. I just want to add that there's been a lot of suggestions and about projects and about kind of tracks and priorities and next steps that the coalition could take. We're so excited to see all those. Please share those ideas by email with the leadership team at contact at IACCPAC.org. We're excited to read them, and we will definitely capture them here in the chat, but wanted to touch a little bit about the decision-making process, about which priorities and which projects kind of bubbled up to the front. And Lisa did a great job explaining our metric with the low impact, high impact, low effort, high effort metric grid. And so we got a question specifically about that. And examining the high impact, high effort sections, are there thoughts about reimagining such efforts to preserve the impact while minimizing the effort? What would this look like potentially? And so I think this could be a really interesting starting off point for some of the conversations around where we invest our time and energy. So would anyone like to take a pass? I'd love to start with you, Lisa, because I love picking on you too. But especially because you presented on that section, what could we do about imagining these things as different quadrants than were already established?
Sure, yeah, and just to give maybe some clarity to how those were decided on as well. So the priorities were kind of identified through the workshop process and as we were having discussions within the workshops with various participants, and then the participants in the workshop all ranked these. So they weren't necessarily ranked just by the people on the screen right now. It was really the collective effort of all the workshop participants. In terms of making things lower energy or lower effort, I think honestly what, in my opinion, would make things lower effort is having more people involved and seeing what kind of doing a stakeholder analysis of who we have within our coalition and who has the maybe connections that are needed for some of these priorities, who has already done some of these priorities before for their disease group or another disease group, and being able to use the expertise in the room and within the coalition and build off of that. So I think that is one way that the coalition can really make it so that, as you know, from something that Patient-Led Research Collaborative couldn't necessarily do on our own without extreme high effort, because it might be a big learning curve, something we have never done before, but maybe another organization has done it before. And so they can kind of lead the way with that. So I think that's a really cool way that we can collaborate and pool our resources together, pool our expertise together, and make some of those really high effort things that are still going to be maybe the most high impact, a little bit lower effort.
Oh, I love that. I love the bringing together the community and you know, shifting those categories based on our capacity instead of based on trying to reimagine them in a different way. Would folks like to jump in? Lauren, I'm kind of going to pick on you now. If you'd like to jump in on that one.
Yeah, just to reiterate, when we were doing that sort of scoring of the priorities and the effort, and in those rooms, in that discussion space, was I think about 60 different nonprofit leaders from different disease organizations. And the amount of talent, it was amazing to see. Oh, I kind of was like fangirling over some of the people that were joining our calls, the people I had not met. So I think there's a lot of different organizations and disease communities have developed expertise in different resources and different tools and different pathways that they're really, really good at on the advocacy front. And advocacy just isn't just, you know, one thing. Advocacy is pushing for research. Advocacy is getting on the news. And so taking the different coalition organizational members that are going to fall into place and sort of highlighting the strengths of different groups and letting them teach. I find I learn a lot talking to other nonprofit leaders about what worked for you guys, what didn't work. Can we sort of, you know, replicate something that was successful in one IACC and sort of expand that out to other IACCs? So I think we're gonna get a synergy when we you know, have stronger relationships in a coalition than each individual organization doing its own thing.
And Emily mentioned it quickly earlier, and I think there was a question about why do we feel that resources are sort of a low effort. It's not because it's easy to do that. It's just because, as Lauren said, many of the organizations already have very strong resources available. And I think it's by sharing that and having greater access to these existing resources, we can really make a big step forward. Obviously, there are going to be some research that need to be created, and that's never easy, but I think there's a lot that's out there. So sharing that would really be incredibly helpful.
Yeah, I also just want to add another caveat. When something was voted on as low effort, I don't think anyone was saying it's easy. All of this is really hard work, right? I think we were viewing it relative to the other things we were voting on. This particular thing was a lower effort thing compared to the other thing that's like super hard to get done. But we recognize, and we also recognize that different organizations and different individuals have different capacities for what is a high effort and what is a low effort. And I think there's room for all of that. And what's great is that if something, let's say there's something that's a really high effort for me, I have no idea how to do this. I don't have the staff that knows how to do it, but Ovid's done it 10 times. Okay, maybe it's a low effort for Ovid. I'm going to just roll with him and say, how did you do this, Ovid? And I think that that's the great thing about a coalition of these orgs coming together, and not just orgs, but the different patient communities that we all operate in.
Here, here. It's been such a privilege and a joy to be part of those collaborative efforts as they come together. And actually, it's a great segue into, I think, a question that we've received in a couple different forms from a couple different folks. So I'm going to try to summarize in a general way. But as important as long COVID care is, and long COVID has been a spotlight that's brought all of these so different IACCs together, folks still feel that doctors are not looking at POTS or ME or MCAS or mast cell activation syndrome in their own individual rights as significant diseases as they should be. So, Lauren, I'm going to throw this one back to you to start us off. But I guess the question is, how can we encourage and still highlight the individual needs of the patient experiences for these specific illnesses, and especially their experiences in the medical environment? And how can we continue to work forward as IACCs while maintaining the work around the individual illnesses and not losing those individual disease needs? So I know that's probably a really difficult question, so I'll repeat it really fast unless you're ready.
Yeah, I think that we think a lot about this, right? I feel like if you get into patient advocacy, if you're starting an organization or you're volunteering for an organization, you're trying to help people. You want everyone to feel better. You want everyone to get back to their life. You want everyone to find their magical treatment that makes them feel awesome. So I think that we, as a community, as a big collective community, I would love to see more people being excited that I want the POTS community to be excited when ME/CFS gets funding. And I want the long COVID community to be excited when Lyme gets funding. We need to be champions of each other, because reality is we are all facing the same stigma, the same lack of access to care, the same lack of interest from pharma, and instead of sort of griping about mine is worse than yours, which sometimes you do hear that on social media, don't do that. Really think about how do we all move us forward together. And a win for one of these patient communities is likely to benefit the other patient communities, because there is so much shared overlapping pathophysiology. And I also want to say there are definitely a vocal subset of people who think, no, none of this is all distinct and it doesn't overlap. And so I don't know that that's medically true, but to the extent that each pathogen, this is the way I've explained it to people, each pathogen has its own fingerprint, right? What COVID does to your immune system is probably different than what influenza does. But for many people, they can end up in the same ME/CFS or POTS or MCAS diagnosis at the end of the day. So we need to figure out what's unique and different and what's the same, and move forward on both of those tracks at once, and not have people sort of being, sort of going at each other over whether it's the same or different. We need all the answers, not just some of the answers. So that's the way I view it. I don't know if that answered the question. But...
No, I think that really did. And Lisa, I'd love to look at you for the next response, because specifically, I'd love to talk about, that was from our kind of patient community side, Lauren. Thank you for that sense. But also from the research perspective, from our data collection, how can we benefit from looking at these diseases holistically rather than in silos?
Yeah, with so many of the progress that we've made in long COVID is because we've been building off of research into ME/CFS, from POTS research, from all of these conditions that overlap or that we've been diagnosed with, and really looking at long COVID specifically as an infection-associated chronic condition, as something that is brought on by a pathogen and has these effects, is what's going to get us to an answer faster for long COVID, but also for all these conditions. And so it's really critical from a research side of things to, when we're doing research on long COVID, look at the subsets of people who are also diagnosed with ME/CFS, who are also diagnosed with POTS, have subsets of people who have those conditions that weren't triggered by COVID, to do what Lauren just mentioned, being able to look at what's different and what's the same. And it's a smarter use of resources that way, given that we have limited of that within our community right now. It's a smarter use of being able to look at these conditions in that lens and do the research that way. And it's really going to help us get to answers a lot faster.
Thank you. And Karen and Ovid, do you want to jump in on that question?
Maybe just to add to some specific activities, some diseases have registries or patient databases. We've heard from Lorraine Johnson about the one that exists for Lyme disease. SALT has initiated a registry for people with ME/CFS and long COVID. I think there's going to be a very interesting exercise in combining those data sets and working together. I think, one thing that I've said before, and I know it sounds kind of funny, but diseases are really, these are human constructs. We think about, we give it a name and we say, oh, that's long COVID, because we feel like it started with COVID. But in reality, as Lauren, as you said, those pathogens can overlap, and you could have EBV and long COVID at the same time. The viruses really don't care. And you could also add a bacteria or or mold exposure on top of that. So it's in our minds, humans try to simplify things. So we think about one thing that triggers something and we give it a name. But the reality is a little bit more complex than that. So I would just ask the people to, I know that names are important, and the way that we talk about those diseases is incredibly important. But sometimes it's important to think about the overlap, and don't get too bogged down about the name or the specific term that we use. I think it would benefit all of us from kind of suspending that from time to time.
Thank you so much.
Can I just add a super
please go ahead.
So I think patients, I am a patient, and most of us are patients. You very often get very attached to your diagnostic label because you've built a community around it. That's where your friends are in the support groups. You've talked to the top doctor in your diagnosis, and they're helping you, hopefully. And so people can be very connected to what they've learned from their own community. And then when you branch out and look at these other communities, you realize a lot of people, not everything is the same, but there is a lot of overlap. So instead of looking at the label POTS, I would say, I want to look at the pathophysiology. Is there a small fiber neuropathy? And it turns out in almost all of these IACCs, there's a small fiber neuropathy. So then looking at, okay, well, why is that happening? Is it viral persistence? Is it Lyme persistence? Is it some autoantibody thing, like trying to get at the essence of this. And if you find the essence of it in one of these IACCs, then you look for it in those other IACCs too, and you probably find that a good subset of people have the same pathology. So I don't want anyone to think we're trying to erase these various diagnoses, because all of us involved in this are very fierce advocates for our own diagnostic label, that the disease that we're advocating for. But we also recognize that we can go further, faster if we work together.
Hear, hear. So unfortunately, we're coming to the end of our time, and I didn't get a chance to get to all the questions. There were so many, but I'm going to try to summarize one and do a rapid fire round for just one quick question, and we have about a minute left. So this question is about how do we include clinicians and scientists and medical experts in this conversation? We talked about how we've really centered the patient advocacy community, getting patient organizations and patient-led organizations centered in the conversation. So what about the clinicians and scientists? Really quickly, who would like to jump in?
I would say that due to the prevalence of long COVID, there are so many physicians that are going to be seeing long COVID patients, and we really need to, again, emphasize the research and medical education needed to treat these patients. And I think that the patient push and urge from all of us in trying to get this knowledge out there is going to more broadly improve patient outcomes for our community. So my ultimate thing is that.
Well said.
And I think it really is its opportunity to invite people to be part of that. And I think that clinicians and researchers actually, when we invite them, and in some cases it's easier for us to bring them together than it is for themselves to come together. So I think this is really an opportunity for us to create this bigger tent. The different specialties, the different scientific silos, they exist, and it's really, I think, in many ways up to us to break them and bring them together. So I think that's going to be one of the key goals of this coalition moving forward.
Absolutely. And the last thing I'll just share is, of course, we have amazing patient scientists who are both patients and medical or scientific experts like Lauren and Lisa, who have been leading the charge. And so patient-led research and all of the efforts that center patient voices can also include those folks who live in both worlds. And so speaking of living in both worlds, we do have to wrap up this panel right now, but I think we've really captured a lot of the questions. We will continue to capture the questions, and hopefully, again, if you would like to get a follow-up, please feel free to email your question to contact@IACCPAC, IACCPAC.org. And I'll turn it over to Lucia to wrap us up. Thank you once again for this wonderful panel opportunity. Thank you to our panelists, and thank you, Lucia.
Thanks, Emily, and thank you so much to everyone for your participation today. We're so excited to further develop our aligned mission and look forward to working with everyone interested in and impacted by IACCs to realize this critical vision to ameliorate the lives of the many individuals living with IACCs around the nation. Please fill out the feedback form by answering the following questions. You can find the feedback form in the chat. We're very interested in knowing if your organization has learned of any new patient advocacy or community-based organizations through participation in the IACCPAC workshops and webinar, whether you have an increased knowledge of how to participate or become more involved in the ICC community following this webinar, and whether you have any suggestions on how to go about further building the IACCPAC. Thank you so much again for joining us today.
Thank you all. Thank you all for joining, and please fill out our feedback form.